Peer Support Education. Um, Up next, we have Dr. Kelly Irons. She is practicing out of the Community Hospital of Anaconda. She's a medical practitioner that's triple board certified in pediatrics and adult and pediatric psychiatry. So give her a warm welcome.
Well, vertically challenged, so. All right. So, like Demetrius said, my name's Kelly Irons, and I work both out of the Anaconda office as well as the Butte office. And I've been tasked today to talk about teens in crisis. And if we're going to talk about teens in crisis, we also have to talk about, with the crisis interventions, we have to talk about prevention a little bit, which frankly, I find a little bit more interesting because I know all of you have been exhausted by the last couple of years in mental health, and we've been doing a lot of crisis intervention. And so I'd like to spend a few minutes talking about the prevention as well. So when I think about teens in crisis, I always think about this idiom of up a creek without a paddle. And I talk to my youth a lot about sort of the river analogy and being kind of, tossed around in the rapids of our emotions. And wouldn't it be nice if we could actually help them fashion a paddle so that they could sort of maneuver the rapids of life and the rapids of a teen brain a little bit better. So, in order for all of us to sort of get into the mood a little bit and to kind of really embrace this, oh, it's not advancing.
Pointed at me.
Oh, there we go. Okay. I'm going to play this little video clip. So these guys do not have a paddle. They're in a paddle boat. This is my favorite part coming up.
Oh my gosh.
All right. So, oops, there we go. So, that's good and fun and everything, but, especially that last scene where they're just, you can see it coming. They're going to get stuck in that hole and it's just going to be a total yard sale. Sometimes we see that in our teens, right? We just know it's going to be bad. And despite all of our intervention at the very end there, they crash and burn. So, again, what can we do upstream to, actually give them a paddle and not a paddle boat? Today we're going to talk a little bit about statistics because it's important to kind of frame all of this. You guys know these statistics, you live them every day. I'm just going to kind of go over them briefly and talk a little bit about pre and post COVID and what we're seeing in our teens. We're going to talk about warning signs and risk factors as well as protective factors. Again, I hope that to be more of a conversation. I know a lot of you guys are on the front lines doing this every day, and so we have a lot of expertise in this room that can kind of put our heads together and talk about what we specifically see in our teens that are particularly concerning for that age group. We'll talk a little bit about the standard of care for crisis intervention and our resources here, and then look upstream at prevention strategies. And then, I'm just getting my phone out so I can watch the time, but I also think that it's really, really important to talk to our youth about this, right? So we can sit in all, our conferences and, put our heads together as professionals and decide what we need to do for our teens. But what better way than to ask our teens themselves what they need? And so I have one teen that gave me permission to video her and what she sees we need. And then we'll talk about what some other teens say too. And then, future collaborations. This is going to take a multi-tiered approach. We all have to work together. We are stronger together in terms of facing this epidemic. And so, how can we collaborate more in our different organizations for the same goal? Because if we're in our silos, as we know in mental health, that doesn't work out very well. All right, so suicide is the second leading cause of death in youth 10 to 17 years of age. Second only to unintentional injury, and it's getting up there neck and neck with unintentional injury, which is kind of terrifying. I think this next statistic is another alarming thing to think about. About 25% of our youth who die by suicide in the U.S. And the suicide rate has increased a boatload, 56% in the last 10 years or so. This is the most recent youth risk behavioral survey talking about what teen behavior looks like. And in the state of Montana, in the previous 12 months, about 10% of teens, high school students, attempted suicide, and 13.5% of 7th and 8th graders. This was even more astonishing for our Native youth at 17%. So, this is touching most of our teens in some way or another. Oh shoot! Sorry guys, I am backwards today. Okay, this graph just shows past suicidal thoughts, plans, and attempts broken down between male and female. So the female is in green and the male is in blue. And your y-axis is the percentage. It's looking at 1 year span. And as you can see, females tend to attempt or have suicidal thoughts a lot more than male youth. Male tend to die by suicide more often, but females tend to attempt. This graph is pulled off of DPHHS's website. It's older data, but I just really like it because it sort of magnifies our problem here in our surrounding counties with Deer Lodge and Silverbow. So it's showing per capita per 100,000 the suicide rate. And again, it's older data, 95 to 2014, but the trend continues. And it's showing the red are the highest rates of suicide in the state, which Deer Lodge and Silverbow are lit up, unfortunately. The national rate is 10.5 per 100,000, and we are over double of that in Montana. We're always in that top tier, 3 or 4 out of the 50 states with suicide rates, and youth suicide is way over twice the national average at 11.9 versus 4.9. Oh gosh. This is also from Carl Roston's report, and I just love this because suicide is multifactorial, right? It's not just one thing. We can't fix one thing and make this problem go away. And we have to ask ourselves, why in Montana do we have such high rates? Well, there's an environmental component. We don't get a lot of vitamin D, and there's been a lot of research in altitude and suicide. The theory is that there is the subthreshold hypoxia that actually increases our suicidal rate due to oxidative stress. And we have to also look at our kind of social surroundings, right? So we're a big state, we're all spread out, there's less connection. We are a state with a lot of firearms. We talked about that, Dr. Yates talked about that a bit, in that most of our deaths by suicides are related to firearms. And there may be some stigma that you guys probably see in your day-to-day settings regarding treatment to mental health. So this speaks to the means a little bit more clearly in that our firearms, our death by firearms, is about 63% of our suicides. And so, if there is a way that we can intervene here, we may save a lot of lives. And how do we have those conversations around access to lethal means without expressing judgment for those that have firearms at home, which is most of us? And how do we educate in a way that they feel comfortable reaching out to those resources when they feel they need to? Sorry, this is a little touchy. Demetrius, can you
Gotcha.
go back one? There we go. So we know that pre-pandemic the trend was bad, right? So on your left there's a graph, and the solid black line is our youth suicide rate, and everyone has been increasing. And then on our right shows Montana specifically compared to the national rate, which we talked about. Ah, okay. We're both doing it now. And so after COVID, it's been worse. And we've been seeing that. We know that in our clinics and our behavioral health settings. I'm sure you have felt that, but this is some data to show that it's absolutely true. So if you look from 2018 to 2020, this is data from the CDC. Young adults and their suicidal ideations was about 10% across the nation, and now it's over a quarter of young adults. This is a study that was recently published that looked at ED visits pre and post pandemic, basically. And this looked again across the nation. And visits for suicide attempts were up in all age groups. Most specifically, you guys, were suicide attempts in young females. So, for whatever reason, girls aged 12 to 17 were over 50% higher. So in 2021, there was a call to action. You may have heard the Surgeon General's, had a statement about this too, but the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatrists, and the Children's Hospital Association all came together and said, this is a huge problem. Like, how do we fix this? Well, it's a national emergency, and it falls on all of us, not just behavioral health clinicians, but schools, parents, community members at large, to start making a dent in this and curbing this trend. They created a blueprint for suicide prevention, which is available to everyone, and it's actually a really nice document that talks about sort of all these different tiers of prevention. So if you're interested in this work, or if you do this work in your own setting, I recommend taking a look at it. When we think about crisis intervention, we got to know the signs, right? So it goes back to those, guys in the paddleboard, right? And you just saw, like, they are so woefully unprepared for this, and you knew it was going to happen. And we know that about 75% of youth have warning signs before they make an attempt. And so if we can catch this and we can, provide resources ahead of time, we may save a life. Like I said, it needs to be a coordinated effort. This is not just one person. This is not just the psychiatrist or the therapist or the school. It's really got to be a group effort. And then we have to remember to provide support for those on the front line. So the crisis workers, some of you in this room, the people that are dealing with this every day, it is really heavy stuff. And we are always the healer and the caretaker, and we can't do anything unless we put our own oxygen mask on first. So really, being intentional about that and aware of that with yourself and whoever you work with is so, so important for the longevity of this work. I could do a whole talk on that, but we don't have time today. Oh gosh, let's see, one more time. Okay, so what are some of the warning signs of youth? Like, what do you think of when you're like, oh, I'm worried about this kid? Self-harm, yep. Yes, that's a big one, withdrawing. They're social creatures, most of them. Their peers are the most important thing to them. What else? Yeah, especially in our male youth, that often shows up before depression. So isolation, withdrawal, good job, brownie point. Externalizing behavior, so more substance use, skipping school, acting out, disengaging in school, really loss of interest of things. Substance use, we kind of talked about. Poor hygiene, this is another one, especially if you know the kid and all of a sudden they're not showering, they're wearing their pajamas. Increased risk taking, sexual promiscuity, attention and focus. I have a lot of kids come in with ADHD complaints that it's not ADHD. If it just shows up all of a sudden, that's depression or anxiety or abuse or something else going on. Oh my goodness, disruptions in sleep. So just like Dr. Yates talked a lot about sleep in the elderly, this is so important in kids too. I talk about this till my face falls off every day about good sleep hygiene. Um, and just what Hannah was saying, like talking about dying, hurting self, actual, self-harm, things like that. So separately, there's some risk factors that make a youth more likely to attempt or have an attempt. So diagnosed mental illness, that's kind of obvious, but especially, if they're psychotic, right, that's going to be a huge red flag. And, that might not be their main complaint, but really trying to sort of, siphon that out. Hopelessness is a huge risk factor. I always ask my teens about hopelessness, and, they get it. They get that feeling, and they'll let you know. Family disengagement. So you'll hear, the teens talk about having validation and feeling heard, right? So if a family is not connected with that teen, that's a huge risk factor. These are folks that I'm particularly aware of, so our LGBTQ youth, our Native youth, those kiddos with chronic medical conditions or chronic headaches, seizure disorders, all of them are at higher risk. Impulsiveness, so, our ADHD kids that may be more impulsive. Family history, so that's super important, right? There is something biologic about, sort of not just suicidal thoughts, but going through with an attempt. Adverse childhood experiences, which I think we had a talk on that this morning. Past suicidal behavior. So past behavior always predicts future behavior. I'm sure all have had those patients or clients that are chronically suicidal, and you feel pretty comfortable managing them in the outpatient setting, right? And so that's part of your sort of acumen as you get to know someone, you sort of know, not that they can't ever, try and attempt, but that, past history is really important. And then, exposure, so kind of those copycat suicides. Access to firearms, again, that is our most lethal way of killing ourselves. And then sort of obsession with suicide and talk. Just checking the time. Okay. Protective factors are on the other side. And this is a big part of prevention, you guys, is starting to talk and change the narrative about, instead of what risk factors do we have? We all have risk factors. Most of us have had some childhood, adverse experiences. But what protective factors do we have? What strengths do we have that are going to pull us through? So obviously coping skills are important. We talk about that ad nauseum, connections with family and community. This may not be your family of origin. Maybe this is a family that you have, adopted because your family of origin isn't connected with you. So that might be someone at the school or a close friend or someone, your band teacher, things like that. Supportive relationship with caregivers. We can do a lot of education about this. Caregivers are often dealing with their own mental health issues and their own sort of adverse experiences. So how do we support the caregivers so they can support their kids? This is a really family systems issue. And I love taking care of kids because I get to talk about this a lot. This probably should happen in the adult world too, and especially in geriatrics, right? Like we really need to involve the whole family. But with kids and teens, it's much easier to do. We need to have those conversations about limiting access to firearms in the home when there's someone with active mental illness or suicide risk. talk about, are you future oriented? Are you looking forward to things? That's that hopelessness piece. And then, are you responsible for your pet? Like, how would, who would take care of your pet if you hurt yourself? Who would, if that's the only like foot you have in the door of thinking about like what would other people think? How would they feel? Then you go with it. All right, so we do some routine screening in our clinics and behavioral health settings. What kinds of screenings do you guys mostly use in your clinics? PHQ, yep, that's kind of a go-to for us too. There's a couple, there's other evidence-based tools. The ASQ is a little bit shorter. Sometimes that's a nice version for kind of primary care clinics. I'd say in most behavioral health clinics, we use the PHQ. The Columbia Suicide Rating Scale is really helpful to sort of address particular suicidal behavior. So if they are positive on that number 9 of the PHQ, the Columbia is a great way to sort of flesh that out. If you guys haven't been to the website, the Columbia Lighthouse Project website, it's a great tool to use Columbia in a validated way. Some of us don't use it quite in the way it was intended, and so then it sort of erodes that validation for how we sort of factor in the risk. And it's like an hour-long webinar, which is really helpful. With teens, we have to get collateral information. So teens are impulsive and they lie to us. And we just have to assume that they're not telling the whole truth. And I love them dearly, but I don't, take much of what they say, at full truth. And so collateral is really, really important, especially when we're trying to figure out, like, does this person need, to increase their level of care? Well, if parents are saying, I can't keep them safe, that's your answer, even if that youth is being like, oh, I'm not suicidal right now. We know it's impulsive. We know those 5 minutes, that 5-minute window of when they think, they want to hurt themselves is the most important window to sort of intervene or not have access to means. So collateral is so important. You guys probably all have your own way of doing some safety planning. There's lots of, documents online that kind of go through it, talking about coping skills, what can we do instead, who are we going to call, what is the, suicide hotline, that kind of thing. But I encourage you, this is, SPRC has a great safety plan guide, which I encourage you to look at. I think you guys can get these slides, hopefully. We'll make sure you get them. This is a great training, CALM training. There was a question before about access to lethal means. How do you talk to families about this? And this is a great training for folks that want to feel more comfortable about this. And it's really non-judgmental, and it's talking about risk and how do we mitigate risk. So I recommend that. And then we have to think of, do we consider emergency care? Do they have to go to the ER? Do I need to see them on a daily basis? Can I, safety plan with the parents to sort of be on quote unquote suicide watch? I came from Salt Lake before I moved to Montana, and we had so many resources for emergency care. We had lots of hospitals and we had lots of beds. And as you know, living in Montana, that is not the case. So we often have to do things that we're maybe a little bit uncomfortable with because we just don't have the resources for it. So how do we do that in a way that we try to maximize safety? And often the question is, can I get parents on board, and can I get parents to sort of, take on some of that burden? If I can't, then I'm much more likely to hospitalize. If they don't meet criteria for hospitalization, meaning they're not at imminent risk for hurting themselves or others, or they, aren't floridly psychotic, then maybe I think about a residential treatment facility. We do have a few in the state. Again, I often look to Utah and Idaho and surrounding states when I can't place them here because we just have limited beds. Or maybe they just need respite from parents. Maybe there's high conflict home environment. We see that a lot. So how can we give them respite and have everything cool down? Sometimes that's just bringing them into the hospital, unfortunately, for a night or two when we're sort of don't have any other options, and then we can safety plan and send them home. I prescribe a lot of medications. I'm a psychiatrist, but in a crisis, often my meds aren't very helpful. So, really, I'm not looking to, if they're floridly psychotic, I'm going to start a, antipsychotic. But otherwise, it's really this sort of community wraparound approach for teens, and how can we reduce stress and how can we make them feel safe. So that's the new national hotline for suicidal ideation. So that's our new, sort of counter to 911, which is live and active in Montana now, which is great. It's not live and active in every state, but you can start giving your folks that number. So we're really good about sort of crisis management, actually. And we've been doing a lot of it. And I know that you guys are probably pretty fatigued. I know I am. And so, like I said before, what if we could prevent that crisis, even a quarter of the crises, and we'd be in so much better shape? So let's talk a little bit in the last few minutes for strategies for youth suicide prevention. Well, it is a systemic issue, like I was talking about, which requires a systemic response. We need to be really careful about overstating causes, okay? So often we'll hear, oh, it's because of bullying, it's because of cyberbullying, it's because of social media. Well, those are factors that influence, suicidal ideation and attempts, but they are not the reason why. It's interesting because specifically with bullying, you guys, if we sort of overstate the importance of bullying and the sort of prevalence of bullying, we may inadvertently kind of excuse the behavior almost and normalize it. And so we have to be really careful. Bullying is a very specific set of behaviors. A lot of kids actually aren't being bullied. A lot of kids are having lots of conflict. Don't get me wrong, and there is negative behaviors, but it's not true bullying. And so by calling it bullying, we kind of normalize it and say, well, everyone gets bullied these days. And we don't want to normalize this behavior. We really want to treat it and to say, if that's truly what's happening, like, we have got to put a stop to it. StopBullying.gov is a great website for parents and for teachers and for folks dealing with youth. Social media is also a huge problem, and I know it's a problem and has increased suicidal ideation and attempts. I feel that. But there hasn't been a whole lot of data surrounding that until this study. This study just came out last year, and it looked at a prospective cohort of students, 2009 to 2019, and looked at their social media use per hours, and then suicidal attempts, ideations, and death by suicide. And it was a pretty large cohort, and it showed that there was an increase, a correlation between increase of social media use and suicidal behavior, mostly in adolescent girls. Again, it's that adolescent girl population that seems to be really affected by COVID and disconnection and social media use. And so really educating parents and teachers and folks about healthy social media use, again, a whole nother talk that we don't have time to go into, because it can be actually really helpful for some kids, but in a moderate amount, in a productive way. So peer-led interventions have been shown to be pretty effective, and there's a few that are evidence-based and endorsed by SAMHSA. One that I'd like to focus on is Sources of Strength. There's also another one called Hope Squad that I worked with in Salt Lake. And Sources of Strength, again, is this, you nominate kids in the high school setting. They're doing it in junior high now, that, sort of run campaigns and learn about warning signs, and are youth leaders in terms of changing the narrative, again, for these youth. Instead of saying, you're in crisis, you need help, you've got all of this going, wrong in your life. Wow, you're really strong and you're really capable, and we can get through this together. We implemented this last year in the Anaconda School District, and it has been really well received. Pretty much like the only thing that's been well received for the youth, in terms of suicide prevention. Family interventions are really important, and this can be tough because we are dealing with substance use in families, and their own mental health, and all of these complex things that make it really difficult for families to have the bandwidth to get on board. So little chunking it, little things that help them become a more positive, involved parent. You kind of stick one in every time you see them. It's this, you're kind of just putting little, buzzes in their ear. All right, so this is the youth that I asked. I asked a number of them, and she sort of compiled this. This is a girl that actually is one of the sources of strength leaders in the Anaconda School District. And I asked her, what do we do? How do we help you guys? Like, we're all like so sad that you guys are all so in so much distress all the time. And we don't know. We don't know how to help you. So this is what she said.
Suicide is a big problem facing our youth today. Many adolescents feel depressed, anxious, suicidal, and this can be caused by any number of things like religion, sexuality, the loss of someone close, especially to suicide, and even their household environment. How can adults help us adolescents? Well, for starters, you could listen and be there for them to the best of your abilities. Try and make sure that they feel seen and heard, and sit there and listen with no judgment.
So I asked a lot of the sources kids about this question, and they are all pretty consistent actually in that they wanted to be heard, they wanted to be listened to, they wanted to feel accepted for who they were. And I think that actually gave me some hope in that the work that we do, that you all do, is so important, and you are those people already for these youth. So you are listening, and you are providing hope, and you are providing acceptance. And so sometimes I know we all just hit our head against the wall and think like, what are we going to do for this kid or this person? They just don't seem to be getting better. But even just being there, that rapport in and of itself is so important. So don't underestimate that when you're getting frustrated. So tolerance, mentoring, freedom of religion, she spoke about, love, a kid said, sexual orientation, time, like just spending time and being there. These are things we can all do, right? This isn't like, these aren't big asks. All right, so we have to have a multi-tiered approach to community-based youth suicide prevention. I bring up the Anaconda Suicide Prevention Task Force. There's a few of you guys that are on it out there in the audience. And this was something, this is just an example. It's sort of in its infancy. We have a lot of work to do, but it's an example of sort of a community-based suicide prevention effort. And really what we did in response to one of the suicides in Anaconda, we said, we can't keep doing this. This is not okay. So we tried to assemble all kind of the key stakeholders. So school, hospital, community groups, law enforcement, and folks with lived experience, right? That's really important. Just like the student that we saw prior, like what are they going through? And we're using so many different tactics to work on collaboration, resource management, trying to get education in the schools, education in family resources, improved community resources with medical professionals and therapists. So it's sort of this kind of stepped approach, this layered approach that everyone is now sort of hoping to come together to coordinate a response. There's not one way to do this. Every community is a little bit different and has different needs. And I think that the more that we can piggyback on each other's efforts and sort of start moving the barge and creating a different type of culture, one of acceptance of mental health and mental health treatment, first of all, and then one of strength-based approach where suicide doesn't have to be on the table. That doesn't have to be an option all the time. Like suffering is a part of the human condition. We know that. We're going to validate it, and it still sucks, and it's still really hard. And we know that we're going to come out the other side, even in that big hole in the river. She came out the other side, right? The other thing is really for youth to make it, they're not going to buy in unless it's peer led, right? They're not going to buy in with these adults telling them what they need to think, what they need to feel. That's never going to work. It needs to come from their peers. That's who's important to them, and that's what will be effective. So looking towards the future, I'm really hopeful, and I'm excited that I'm here today and got to speak to you all. And I'm excited we're all here in the same room. And I want to thank you for all the work you've been doing, because we certainly couldn't be doing it alone. And I think that I'm really hopeful. I do think that we can move this barge. I do think that we can change the trajectory of these youth, and that we can, sort of look at all the ways, the YAM program and signs of suicide, and, putting all of these together, we are going to affect change. The other piece that I want to impress upon you today is that we're a smaller community, which gives us this huge advantage to affect change. I came from a big community in Salt Lake, and it was really hard to do anything, in the school systems or with local government and things like that. And so let's capitalize on that together so that we can affect change for our community. These are some resources that have really helped me, especially when we are sort of assembling the task force and when we're trying to come up with action items and plans for it. So specifically, the American Academy of Pediatrics, the Blueprint, as well as the WHO Preventing Suicide and Community Engagement Toolkit has been really helpful. The JED Foundation is another nonprofit organization that tries to combat youth suicide, and then of course SPRC and SAMHSA and all of those. There's tons of resources out there. I'm always available to, how to find me. You could just call Community Hospital of Anaconda and somehow they'll locate me. But I'm happy to give out my email as well. If people want to collaborate or have ideas or solutions to the problem, I'm always interested to hear. Questions? Either you're all asleep or I was a really good explainer. I don't know. Anyway, those are our references. Yeah. No, I have not. What is it? Nice. Yeah. Oh, I would love to. I definitely will. Thank you. Yeah.
How do you integrate ACEs into your therapeutic approach?
Yeah. That's a great question. And, one thing that I really noticed when I moved here are the amount of intergenerational trauma and the amount of trauma here. I mean, it's quite astonishing coming from, I've practiced, kind of all over the Mountain West in bigger locations, and it's impressive. So that being said, I really take a trauma-focused approach, and I assume that they're there, unless proven otherwise. I'm shocked if they're not. And knowing that, especially in my formulations of what I diagnose with as a physician, I'm using that sort of trauma base to understand what's going on versus slapping on, just some DSM, diagnosis. And I use a lot of medication, but I also am very conservative because a lot of our medication actually worsens trauma symptoms. And so I think that we all have to sort of practice in that trauma modality. And in therapeutically, just knowing that we have to be really careful and intentional about where we go and how we do it. Yeah. Okay. All right. Well, thank you so much. I really appreciate it.